Hello, my name's Ian McCall, and this is one of the Consultations in Dermatology video series. Today we're going to talk about Alopecia areata. This is one of the most mysterious diseases I think you're ever going to see. It can come out the blue, it can affect any age group, it can affect just small areas of hair in the scalp, or it can affect areas of hair the body over, except those in the nostrils and those that grow from the external ears. Why those particular hair follicles survive this condition, no one really knows. It appears that this is an autoimmune disease, and there's certainly an increased incidence of other autoimmune diseases in families where this condition occurs. And in Alopecia areata, I think if you look at families, there's about 10 to 20% history of it within the family. The precipitating factors, who knows? People have looked at infection, they've looked at responses to viruses, but I think the only thing in my practical experience that I've seen is acute emotional stress. Presumably that affects some aspects of the immune system via the hormonal side of things. But the honest answer is that we don't know. So basically, as I've said there, it's an autoimmune disease in all age groups, complete hair loss in involved areas of the scalp. In other words, you don't get any broken hairs there. There is complete loss. The scalp surface is bald. The thing about alopecia areata, though, is that the follicular openings are still patent. They're still there. You can see them. And that's important because there are other types of hair loss disease which are called scarring alopecias, where the hair follicle is permanently destroyed and the follicular openings go as well. So you just have a very shiny surface there. The other thing I've said there, it may spontaneously resolve with initial growth of white hairs, because it's another interesting thing. Sometimes the disease process just affects the dark hairs, and all these dark hairs can fall out, and some white hairs can remain within the balding area. And allegedly this is responsible for this phenomenon that some people talk of, where severe emotional stress has made their hair go white overnight. It's basically they've had a lot of white hair, but they've lost all the dark hair. And the other thing is alopecia areata may be associated with pitting of the nails, and trachyonychia and some longitudinal ridging, but it's the pitting we tend to think about. So let's have a look at some of the images in this condition. Here we've got someone who is verging on alopecia totalis. In other words, they've virtually got loss of all the hair on the surface of the scalp. You can see the eyebrows have been lost significantly here as well. Alopecia universalis is where you lose body hair all over. There's the more typical presentation in a young child. These bald areas, no inflammation to be seen. If you do a hair pull test and you grasp some of these hairs here, they'll come away and they'll usually have a small bulb on the end of them, much in the same way as you do in telogen effluvium. Occasionally the hair shaft will break, but not often. Usually you will get these little bulbs on the end of them. And if you look carefully around the outside edge here, you may see what are called exclamation mark hairs. And this is where the distal part of it is thicker than the proximal part near the scalp surface. And it relates to the way in which the hair follicle is damaged by the immune attack of lymphocytes deeper in the skin, and how the hair is damaged and how it's extruded and then breaks. They can be quite difficult to see, but once you get your eye in with them, you can get it. So this can come on quite quickly. There's usually no warning to the patient, and someone else usually comments on it. The differential in a young child like this might be tinea capitis, but in tinea capitis, the fungus is involving the hair shaft, and the hair shaft will break, so there'll be broken areas of hair shafts here. There's often going to be a little bit of scale. There'll be a little bit of redness as well. You don't see that in alopecia areata. There's much more extensive alopecia areata. you can see a large area of the scalp has been lost here. There's a few hairs that are persisting in some parts, but large areas have in fact been lost, and the activity is usually at the edge here. We'll get into treatment just in a minute or two, but let's have a little look. Again, here's someone who's chosen to shave his head because of the extensive involvement. Look at the extensive involvement all the way right down to the occipital scalp here. And yet you've got hair growing in these other areas here that is still growing normally. Why the body's sort of picking out some bits and not others, really we have no idea. The other differential diagnosis you've got to consider in this condition, one might be syphilitic hair loss. In secondary syphilis you can get patches of hair loss, but again usually the hair is partially damaged and breaks. There may be some scale in the surface, and it's not this complete loss that you see here in alopecia areata. Let's have a look. Yeah, sometimes it can only affect the beard area in males. It may just be like this area here or like this area here without any involvement of the scalp. And occasionally it can just affect the beard area and not affect the scalp at all. Sometimes it can be very localized, and it may just affect the eyelashes. You can see how there's some residual lashes here, not much. The other thing you've got to watch is the condition of trichotillomania, where someone's pulled the hairs out. And it's much easier to pull. I always have to feel with my own eyelashes when I do this. It's much easier to pull the upper eyelashes out than it is to pull the lower eyelashes out. This is meant to show, here you've got alopecia areata, but see how some of the grey hairs are spared here. This is what we were talking about earlier on. And sometimes when the condition reverses, the hairs that will grow back first will be grey hairs. And then the hair will subsequently pigment. So you can have the distal portion of it grey and then suddenly pigmentation of the proximal portion of it. This was the differential of trichotillomania that I was talking about. It's rare in trichotillomania to get complete baldness. You tend to have residual hairs like this. You may have hairs broken at different levels because of the twisting and the pulling that's required. I mean, some hairs will be pulled out by the roots, but most will be broken. And you don't usually get any redness or scaling in trichotillomania either, because of the nature of the process. It's usually quite sharply angulated like this as well. Can be difficult diagnosis, though, to make with certainty, and it's not one you want to make without being certain. Here's another condition that looks like alopecia areata, but it isn't, because if you were to look very carefully, if we had a real close-up of this area here, you'd see that there were no follicular openings here. This is quite shiny, and this is scarring alopecia. This is called pseudopelade. I think it also used to be called footprint. It was described as footprints in the snow. In other words, you can have quite normal scalp, and then you've got these bald areas in between, but with complete baldness and with scarring here, no follicular openings visible. And it's a burnt out stage of some of the scarring alopecias that can cause complete baldness. And those scarring alopecias, we'll come to this one first, include this condition, which is discoid lupus. Discoid lupus and lichen planopilaris, lichen planus affecting the scalp, both can involve the follicles, the follicular openings. There's more follicular plugging in lupus than there is in lichen planus, but I find it difficult to tell the two apart because you can involvement just of the scalp without much elsewhere. You need a scalp biopsy, and it will show you lymphocytes attacking the hair follicles themselves and attacking the superficial epidermis here. That's why it's red. That's why it's inflamed. If you were to look at the histopathology of alopecia areata, the damage is down low. It's down near the bulb of the hair follicle rather than along up the sides of the follicle or on the epidermal surface. Well, there's no epidermal involvement in alopecia areata. That's why there's no redness. So these two conditions, lupus and lichen planopilaris, are the ones you have to remember when you're considering this condition perhaps in an older person. But there'll be the redness, the inflammation, and the follicular plugging that will tell you. There are, of course, a couple of other conditions that may look as if they're alopecia areata. And this is the condition of follicular mucinosis, where again, we don't know the cause of this. Mucin's deposited along the wall, on the side walls of the follicle, and it damages the follicle and the hair falls out. And this can affect the scalp, but classically it will affect the eyebrows. So follicular mucinosis, alopecia mucinosa, is another condition to consider. But let's go back to some of our earlier images here. Let's take the next one. Treatment. What are you going to use to treat this condition? Well, we said essentially it's an autoimmune disease, so you've got to shut off the immune system in some way. One of our best preparations for doing that are steroids. The issue here, though, is if you give this person oral steroids for their alopecia areata, you've got to give them high doses. And you're talking 50 milligrams a day or higher. The problem is that's going to have side effects over time. Now, sure, it will shut off the immune system, but it will make them more susceptible to other infections, other problems. And the hair will start to regrow. But generally, as you slowly withdraw your oral steroids, the hair will start to fall out again. It can be useful in an acute situation where you're trying to shut the process off, but I wouldn't use them for any longer than 4 to 6 weeks. And I'd be reducing the dose over that time. The other way you can deal with it is intralesional steroid. You take 10 milligram per mil Kenacort, take 1 mil of that with 3 mils of local anesthetic and with a bit of adrenaline, and you inject tiny amounts, maybe a centimeter apart, just subcutaneously here, all across the scalp. I know some of my colleagues may use as many as as much as 20 milligrams in one session for this. I tend to not go above the 10 milligram myself. And you supplement that with some topical corticosteroid, such as mometasone lotion or betamethasone lotion, Elicon, or some diprazone lotion. And you apply that twice daily. It's in an alcohol base. The problem with just that on its own is it may not penetrate enough, so that's why the injections are useful. Now, in general, the injections will work, but it takes about 3 weeks for a new hair to start appear, to grow again from the papilla of the hair and grow up and come above the surface. So you see them again at about a month's duration, see how it's going, and repeat the injections there. I may do these injections 3 times, and if there's no at monthly intervals, and if there's no sign of regrowth at that stage, then I don't bother going on with it. There are other ways to try and suppress the local immune reaction here, and first of all, a substance called dithronol can be used. It can be it's a tar-like substance, and it's used in concentrations of anything from 0.1 to 2%. The high concentrations, if you're going to put them on, you have to leave on only for 10 to 15 minutes and wash off. The low concentration you can leave on overnight, 0.1%. The idea is it induces an irritant contact dermatitis, and that dilutes the effect of any autoimmune attack, and the hair may start to regrow. But of course the problem is that when you stop the therapy, or when you get hair regrowth and it becomes more difficult to put the dithronol on, then the autoimmune process may act again and the hair may fall out. There are more potent contact sensitizers that you can use, including DCP, diphenylcyclopentone, I think it's called. And that you have to make the patient allergic to it first by putting a higher concentration on the inside of the upper arm, and then you use a very low concentration on the surface of the skin. You've got to watch this stuff, in that if you get it on other parts of your body, you'll certainly get a good contact dermatitis there. And the nurses who may be applying this, they have to watch they don't become allergic to it as well. Again, it suffers from the same problems as the dithronol. Although the dithronol induces an irritant contact, this DCP induces an allergic contact, and it seems to be more effective in causing hair regrowth. In days gone by, we used to use PUVA, oral solens and UVA light, to suppress the local immune reaction there. And it did work. You did get hair regrowth. But again, it tended to fall out when the hair regrowth became such that the light couldn't penetrate anymore. So this is a very frustrating condition. We still don't have therapies that are effective. The main thing to understand, though, is this is a cosmetic problem. Now, a very significant one, I'll grant you. Women are much luckier than men in that they can wear wigs and wear them quite happily. Many women look fantastic in wigs. It's much more difficult for a man to get a toupee to work well in these sort of circumstances. And most men, in fact, who get this condition severely just shave their head, which is quite a fashionable thing nowadays, so it's not such a big issue. I would hope that in the future there will be some treatments for this disorder. The psychological effects on some people are considerable, and you shouldn't dismiss them. So, alopecia areata, a condition that we'd like to know more about, a condition that can affect all age groups. But remember, no inflammation, the follicular openings are still intact, little exclamation mark hairs at the edge. And the thing is to reassure patients that even without treatment, the majority of cases will spontaneously get better. And I think statistics sometimes given that 50% of cases will only occur once, and the patient gets over it and they're fine. But in the other 50%, they may get repeated attacks of alopecia areata throughout their life. So this is a disease that I've looked at for many years and considered, but really haven't had great success in treating, other than with the intralesional steroid, and the topical steroid, which is useful. The other little area I should have mentioned is eyebrows. This is an area where you can use diluted intralesional steroid carefully and placed just in the dermis, and you can virtually always get the eyebrows to regrow. So if you've got a condition like this, see your dermatologist. They can do something to help. It's not an easy condition. Spontaneous regrowth does occur, and I hope that in the future we can find both the cause and ultimately a relatively simple cure for this disorder. Thank you very much.